Yes, we're good to go.
Hello and good evening, everyone. On behalf of Team ISPAE ACES, I welcome you all to the 32nd ISPAE Academics and Clinical Education Series today on 46XY DSD. Before we proceed, I would like to request everyone to put questions in Q&A section if you have any. I now invite our President of ISPAE, Dr. Anurag Bajpai, sir.
Thanks a lot, Dr. Jalak, for this wonderful program, which has been running successfully for the last couple of years, and it's really brought so many new information and knowledge to all the ISPE membership. And to continue that, we are going to talk about a very, very important topic. And we specifically chose XYDSD because this is one area where there is a lot of controversy, not only in terms of what really is XYDSD, what are the causes, what tests should we do, whether we should focus more on the diagnostic test or go more towards genetics, and how do we manage that in that perspective. ACES is the pivotal as far as the implementation of its big goals are concerned, which include spreading and improving the quality of care of pediatric endocrinology in the country. And this program has been one of the flagship programs over the last couple of years. And it's really a tremendous pleasure that we have Professor Olaf and Professor Sudha, who have joined us and who will enlighten us, along with two very interesting cases from Swati and Nimisha, being moderated by Dr. Divyalakshmi and Dr. Kaushik. So it's going to be a very interesting next couple of hours. And before I start off the program, I'd like to introduce Dr. Divyalakshmi, who is working as Associate Professor and Consultant Pediatric Endocrinologist at Sri Ramachandra Medical College and Medical Center, Chennai. She has been working a lot in terms of DSD, and she has been part of the expert panel from the Tamil Nadu government, which has been playing an important role in terms of leading the roles overall in terms of guidelines for treatment and surgeries on individual DSD. She's also part of the Type 1 Diabetes Project, has been closely associated with Indian Society for Pediatric Endocrinology, and in fact is one of the leading persons working in this field in the Tamil Nadu region. So over to you, Dr. Divyalakshmi.
Thank you, sir, for the kind introduction. So without much ado, we will start with the first case presentation. So I now introduce Swati Ramakrishnan, who is a senior resident from Department of Pediatrics at Lady Harding Medical College and Kalavati Saran Hospital. So she will be presenting a case on 46XY DSD. Over to you, Swati. Her case has been moderated by none other than, it has been mentored by none other than our own Preeti Singh and her team. So, Swati, are you there?
Yes, ma'am.
Yeah, you can start presenting.
Start sharing, yes.
Good evening, everyone. I'll be presenting a case on XYDSD. This was a case of a 3.5-year-old child who was a resident of UP, who was born out of a third-degree consanguineous marriage with the sex of variant being male. He presented to us with the complaints of recurrent episodes of fever, vomiting, and generalized weakness since 1.5 years of age, and complaints of abnormal body movements, 3 to 4 episodes, also noted since 1.5 years of age, and passage of urine from the undersurface of penis. Coming to history of presenting illness, the child presented with recurrent episodes of vomiting, which was associated with excessive lethargy, generalized weakness, and decreased oral acceptance. These episodes occurred every 3 to 4 months, each preceded by febrile illness like URTI or acute gastroenteritis, requiring hospitalization for IV fluids and supportive care. The child also had history of generalized tonic-clonic seizures, 3 to 4 episodes noted since 1.5 years of age, which was always associated with hypoglycemia. There's history of increased pigmentation of the oral mucosa and genitalia as given by the mother. There's also history of passage of urine from the undersurface of the penis, and there's history of salt craving and poor weight gain present. Antenatal and birth history were largely uneventful. There was no history of maternal virilization, drug intake, or infertility treatment. It was a full-term normal vaginal delivery with smooth perinatal transition. The child was born out of a third-degree consanguineous marriage. There was no family history of amenorrhea, infertility, or early neonatal death. However, there is history of atypical genitalia and similar complaints of recurrent episodes of dehydration noted in a maternal cousin. Coming to the past history, at 3 years of age, the child was evaluated for these complaints in an outside hospitals. Given the history of recurrent episodes of hypoglycemic seizures, they had kept up suspicion of inborn error of metabolism, and some initial investigations were done, which showed at that point the sodium was 131 and potassium was 4.5, and TMS, GCMS was done as well, which was normal. And the child was started on anti-seizure medication. At presentation to us on examination, the child had tachycardia and hypotension. BP was noted to be below the 5th centile. And on general physical examination, there was no dysmorphism noted. However, there was increased pigmentation of genitalia and oral mucosa was noted. On anthropometric parameters, the anthropometric parameters were suggestive of severe underweight in the child. On the examination of genitalia, the child was noted to have midshaft hypospadias and a single urogenital opening with a stretched penile length of 3 centimeters. The scrotal folds were normal and bilateral gonads were palpable, and the volume was that of 2 ml. The EMS score was that of 10 on 12, suggestive of mild undervirilization. The systemic examination was normal. On investigating the child at our hospital, the child was noted to have hyponatremia with a sodium of 126, also had hyperkalemia with potassium going up to 6.8. So given the history of recurrent salt wasting crisis and hypoglycemic seizures, along with undervirilization, a suspicion of congenital adrenal hyperplasia with adrenal insufficiency was considered. With differential diagnosis of star mutation, P450 side chain cleavage enzyme deficiency, 3-beta hydroxysteroid dehydrogenase deficiency, POD deficiency, or congenital adrenal hypoplasia secondary to DAX1 or SF1 mutations. Given that all the 3 steroid pathways are involved, a proximal defect was more likely, either being a star mutation or the side chain cleavage enzyme deficiency, or a 3-beta hydroxysteroid dehydrogenase deficiency. Hence, we went ahead with...
Swati. So I have a question for you. So why do you think in terms of CAH? See, all your symptom points towards adrenal insufficiency, okay, right?
Yes.
So any adrenal insufficiency child would be having similar complaints, yeah, right? So affecting salt pathway, the sugar pathway, and then of course the sex steroid pathway may not be affected, isn't it? So so what made you think of CAH in this patient?
Ma'am, all the 3 pathways involved, along with the presentation of salt wasting crisis, and there was also a history of hyperpigmentation that was noted. That is suggestive of ACTH, elevated ACTH levels, ma'am.
Okay, so the hyperpigmentation was more so in the groins, right?
Yes, ma'am.
So
In the
genital region.
Yes.
Yeah.
Yes.
So have you noticed any palms and soles pigmentation?
In the oral mucosa, it was noticed. Yes.
Mucosal pigmentation was there. Okay,
yes.
Right. So that says the ACTH is high. So which do you expect the same thing to happen in adrenal insufficiency?
Yes.
Okay, right. So why CAH? My question is why CAH? It could be simple adrenal insufficiency gone unnoticed, right? So why do you think in terms of CAH? So before we go into investigation, so see, clinical examination and assessment are very important, isn't it? Yeah. So what other sign the child had? Does he have any symptom that is suggestive of the sex steroid abnormality?
Yes, ma'am. The child had undervirilization. The child had hypospadias.
Yeah.
Yes,
So that is
mid-shaft
what.
hypospadias was present. Hence, there was also suggestive of androgen. There was androgen steroids were also involved, ma'am. Hence, we were considering a possibility of CAH.
Yeah.
Yes,
Yeah.
ma'am.
Good. Thank you. You may proceed. Yeah.
A steroid panel was done by LCMS, which showed ACTH was markedly elevated, and the rest of the steroid precursors were low. The 17-OHP was low, androstenedione was also low, and cortisol was inappropriately low for the ACTH levels, and DHEA was also on the low normal side. And the karyotype was done, which was suggestive of 46XY, and also the ultrasound done showed that there were no Mullerian structures. Now, considering that the DHEA was on the lower side, the possibility of 3-beta hydroxysteroid dehydrogenase deficiency seemed less likely, and possibility of star mutation and side chain cleavage enzyme deficiency seemed more likely. Considering the clinical presentation with hypotension and hypoglycemic seizures, the child was initially started on stress dose hydrocortisone at 100 mg per meter square per day. Once the child was clinically stabilized and the electrolytes were normalized, the dose was gradually reduced to 12 mg per meter square per day. Along with that, fludrocortisone was added at 0.1 mg once daily. And the child was discharged on this therapy. On follow-up, the child did not have any further episodes of salt crisis or hypoglycemic seizures. However, after 4 months when the child presented to us in April 2024, the child was noted to have hypertension with BP recorded more than 95th plus 12th centile on more than two episodes. And the child also was noted to have hypokalemia. Hence, now the child had presented to us with hypertension and hypokalemia. At this point, we had a suspicion of either therapy related, since we were giving supraphysiological doses of glucocorticoid along with the fludrocortisone. We had a suspicion of therapy related hypokalemia and hypertension. However, we were also in a diagnostic dilemma if it could be something like 17-alpha hydroxylase deficiency, although the initial presentation and steroid panels were not suggestive of the same. At this point, the fludrocortisone was withheld and hypertension was controlled after adding 2 antihypertensives. The potassium normalized after supplements, and we planned for a genetic workup, and the whole exome sequencing was sent. The report was suggestive of a homozygous 3 base pair deletion in exon 3 of CYP11A1, which was homozygous, and it was suggestive of side chain cleavage enzyme deficiency. However, this particular variant had not been reported in major population databases and was classified as variant of uncertain significance due to lack of functional evidence. At follow-up, the hydrocortisone was reduced from the supraphysiological doses to that of physiological dose. From 12 mg per meter square per day, we reduced it to 8 mg per meter square day. Eventually, the hypertension was controlled. The antihypertensives were tapered and discontinued, and the fludrocortisone was restarted at 0.1 mg per day. At follow-up, the electrolytes remained normal. The sodium remained at 140, and the potassium levels also remained normal. And the child started to gain weight and also was growing well. And the BP record subsequently remained normal. Here is the genital examination compared from December 2023 at first visit to us as compared to the last follow-up, which was in September 2025. The hyperpigmentation has significantly reduced. And we can also note the midshaft hypospadias and chordae in these images. Now, coming to the follow-up and long-term management plan for our patient, we are planning to keep the child under multidisciplinary team DST clinic follow-up with pediatric endocrinology, pediatric surgery, psychology, and gynecology. For the endocrine management, the child is currently on physiological doses of hydrocortisone, and the parents have been counseled regarding the stress dose that is required during intercurrent illnesses, and fluorocortisone for mineralocorticoid replacement. The child is currently being planned for the hypospadias repair under pediatric surgery team, and psychosocial and developmental support, regular growth monitoring and developmental checks are being done, and psychological support is being provided for the child and family. Pubertal and reproductive planning aims at monitoring for hypogonadism and plan for hormonal replacement therapy as required. Fertility potential is typically reduced, however, data is limited for the CYP11A1 mutations, and the genetic counseling is ongoing for the parents. Coming to the 46XY DSD, the etiology for 46XY DSD is broadly classified into either disorders of gonadal development, disorders of androgen synthesis, or disorders of androgen action. Our child had disorders of androgen synthesis, likely congenital adrenal hyperplasia. And amongst the disorders that cause undervirilization in 46XY, these disorders being star mutation, side chain cleavage enzyme deficiency, 3-beta hydroxysteroid dehydrogenase deficiency, 17-alpha hydroxylase deficiency. Amongst these, star mutation and side chain cleavage enzyme deficiency were a close differentials for our case, since these are the two possibilities in which all the steroid precursors are reduced and ACTH is markedly elevated. 3-beta HSD was unlikely since our DHEA levels were also low, and 17-alpha hydroxylase was less likely since the child clinical presentation was that with salt wasting crisis and not hypertension and hypokalemia. And 17-beta HSD 5-alpha reductives were not considered since the child also had features of adrenal insufficiency with salt wasting and hypoglycemia. Coming to CYP11A1 deficiency, CYP11A1 encodes mitochondrial cholesterol side chain cleavage enzyme, which catalyzes the conversion of cholesterol to pregnenolone, which is the first step in steroidogenesis. These variants cause primary adrenal insufficiency and 46XY DSD. The literature demonstrates a wide range of phenotypes in CYP11A1 related side chain cleavage enzyme deficiency, ranging from classic or severe forms which present in the form of neonatal adrenal crisis and a female phenotype in 46XY, to a partial or milder phenotypes where there is delayed primary adrenal insufficiency, along with either mild undervirilization or sometimes even a normal main genitalia. A systematic review was published in 2022 in Clinical Endocrinology Journal by Padite et al. It was a systematic review of genetically proven side chain cleavage enzyme deficiency patients. The study separated the patients into those with typical male genitalia and those with atypical genitalia. All the patients were noted to have global steroid reduction with markedly elevated ACTH. However, distinctive genotype and phenotype correlations were found where there were genotypes that were explicitly associated with male external genitalia, and these genotypes correlated with spontaneous puberty, normal prepubertal gonadotropins, testosterone levels, and occurrence of testicular adrenal rest tumors. Primary adrenal insufficiency, severity of biochemical markers, and adrenal morphology overlapped between both the categories. 17-OHP was often normal or low, hence it has been missed in the newborn screening. Adrenals are usually normal or atrophic as compared to the star mutations where the adrenals are enlarged. Coming to the genotypic and phenotypic correlation, mutations causing nonsense or frame shift mutations result in no enzyme being formed, leading to a severe phenotype of atypical genitalia adrenal crisis in the neonatal period. A missense mutation also leading to a severely unstable enzyme could also lead to a severe phenotype. However, a missense mutation in which there is partial activity present leads to a protein with residual function, leading to a milder phenotype. The mutation in our child, which was a 3 base pair deletion in the exon 3, which is a catalytic core, the functional predictability is that of maybe that may alter the folding or a catalytic function, which can usually lead to partial loss of the enzyme activity, which can lead to variable phenotype depending upon the zygosity. The key points being the CYP11A1 mutations lead to broad phenotypic spectrum with variable onset of adrenal insufficiency. The hormonal profile usually shows characteristically very low cortisol and androgen with markedly elevated ACTH. The diagnostic challenges include that cases are frequently misdiagnosed at other forms of congenital adrenal hyperplasia, and the newborn screening may miss these infants as it is a 17-OHP based screening. Early genetic testing is critical for accurate diagnosis and tailored management, and physiological hydrocortisone with fludrocortisone remains the mainstay of treatment with dose titration to avoid complications such as hypertension or hypokalemia. Family screening is recommended as asymptomatic carriers or mildly affected relatives are common. Reproductive and long-term concentrations include risk of gonadal dysfunction, hypogonadism, and testicular adrenal rest tumors. Requires a lifelong follow-up. Thank you.
So wonderful presentation, Swati. Congratulations to you and to Dr. Preeti Singh as well, if she's here. And so I don't think we have questions. No one has put it up in the chat or this thing. Okay. So a very interesting case indeed. Okay. Yeah. So you had a child presenting with the salt wasting, hypoglycemia, and there is some evidence of a hypogonadism. Okay, right? So so all 3 lines are affected. So you thought in terms of CAH, and then after initiation of treatment, the child had hypertension.
Yes.
Okay, so see, in a setup where, like, there is no possibility of genetic testing or so. I mean, you also must have waited for some time to do the genetic test, and before you got the results. Yeah. So in that scenario, like, what are all the causes of hypertension in CAH?
Yes, ma'am. In CAH, the causes leading to hypertension could be the etiology itself, the mutations causing 17-alpha hydroxylase deficiency or 11-beta hydroxylase deficiency itself can present with hypertension and hypokalemia. However, other than that, in a child who had presented to us earlier with salt crisis and later has developed hypertension, the etiology is most likely to be therapy related, because we do give supraphysiological doses of glucocorticoid along with fludrocortisone. And this is more commonly seen in younger children who have more sensitive receptors and who receive a higher dose of the glucocorticoids.
Yes. So, and also when we are writing and giving, my last point I would like to add is, when we are writing and giving test steroid protocol, we tell like double the dose of steroids, triple the dose of steroid on these events. Okay. So sometimes what parents do, they will also double or triple the fludrocortisone as well.
Mm-hmm.
Okay, right? So, and you know that fludrocortisone has a long half-life. Yeah. So, so apparently that also could be a reason. So one has to be very vigilant about it. Okay, right. So, and you have already pointed out that the hypertensive forms of CAH. Okay, right. The one point that will be very sparking will be the hypokalemia. Okay, right. So we had couple of patients who were in fact presenting with muscle weakness and all those things. Okay, right. So that was the presentation, and when we retrospectively, looked into, then prospectively when we evaluated, we found out that they all have been having some other thing, and the CAH was diagnosed ultimately. Okay, right. So yeah, that was a very interesting case. I think we have one comment. Renin could have helped. Okay. So would you like to? So Lokesh has mentioned that doing a renin could have helped. Yes, very well. But then we have an assay thing as well. Like if you do it, and the supine posture related variation is there, and the child should not cry, and all those things are there, and the child should not be on antihypertensives. Okay, so when you want to do a renin sample, so all those precautions should be taken up. Okay, yeah. So yeah, that is all from my end. So thank you, Swati. Can we proceed to the lecture presentation? We can move on to the next.
Yes, ma'am. Yes.
Yes. Yeah. So it is indeed my privilege to welcome Dr. Sudharao ma'am. Who needs actually no introduction for herself. She is one of the very lovable pediatric endocrinologists, senior pediatric endocrinologist of our country. And ma'am is professor of pediatrics and Chief Division of Pediatric Endocrinology at Wadia Hospital for Children, Mumbai. And she is a honorary consultant from Tata Memorial Hospital, Mumbai, and Jupiter Hospital, Thane. Over to you, ma'am, for your lecture presentation on 46XY DSD assessment.
Thank you,
Thank you,
ma'am. Thank you, Divya. A very good evening to everyone. Can I share my slides, please?
Yes, yes, ma'am.
I would like to thank Anurag and everybody to have given me this opportunity to be here today. It's always a great pleasure to speak to stalwarts and discuss with students. Yeah. Can you see my slide and slideshow now?
Yes, ma'am.
Okay. Thank you. I would like to, that was a wonderful case presented. Actually, it's given a background as to how we would discuss a child with the 46XY DSD. Greetings from Wadia Children's Hospital, one of the premier multi-speciality, super speciality pediatric hospitals in our country. So when we speak of assessment, I was hearing into Professor Olaf a while ago. The assessment and investigations and diagnosis is getting more and more difficult as we get to know more and more what we don't know. So when we speak of XY-DSD, we all know differences of sex development or disorders of sex development is defined when you have the chromosomal gonadal anatomical sex, which is atypical. And it's not very uncommon. 1 in 4,500 babies are born with some form of genital anomaly, especially when you have a busy birthing unit. You may be seeing genital anomalies quite often. So what is unique in XY-DSD is it has several phenotypes, and we should be aware of excluding life-threatening disorders in these cases. And often the clinical and genetical presentations and conditions are very heterogeneous. There is no one kind of approach or one kind of picture which might fit all. And the definitive diagnosis, like I was hearing to 5-alpha versus the spectrum, is very challenging. And gender assignment is often to be avoided before expert evaluation, and in this era, possibly of a molecular diagnosis. So, coming into some part of the embryology or the ontogenesis of sex development, XY sex development, we know that the undifferentiated gonad in the presence of SRY, supported with SOX9, gets determined as a testis, and the testis in turn differentiates into Leydig cell and Sertoli cells, whose jobs are very specified in the form of producing testosterone, which brings about the differentiation of the Wolffian ducts and the external genitalia, also the descent of the testis, and the Sertoli cells, which brings about the regression of the Mullerian structures. There are so many genes which are shown and transcription factors which are shown in this picture. But as I'm talking, I'm sure we do not know many more things which is happening in terms of gonadal determination, gonadal differentiation, and then the differentiation of the internal and the external genitalia. There is also one more spectrum of disorder which causes XY-DSD, that is the presence of abnormal hormonal milieu in the intrauterine life, the spectrum of CAH. So when we speak of the spectrum of disorder of XY-DSD, it could be a dysgenesis of the gonad alone, or it could be a dysgenesis of the gonadal with adrenal affection. It could be a problem affecting the adrenal steroidogenesis, which could be gonad specific, or it could be both adrenal and gonad specific, or maybe just adrenal specific. Or there could be a disorder of adrenal action, androgen action, the androgen receptor and the conversion of androgen to 5, meaning testosterone to 5-dihydroxytestosterone. There could be a problem related to AMH synthesis, the anti-Mullerian hormone synthesis in action. The spectrum of vanishing testis syndrome, of which I would like to hear from Professor Olof as to how this really goes about happening. And there are these developmental anomalies and presence of environmental endocrine disruptors, of which we also as yet don't know as to which pathway of the ontogenesis those affect. So the clinical phenotypes are based on what happens in terms of these types of spectrum of disorders. So baby with 46XY DSD could present with micropenis, could present with just hypospadias, could have a unilateral or bilateral undescended testis, or a female-looking genitalia which would look like a sex reversal, a failure to thrive, hyperpigmentation, presence of dysmorphic features associated, or an XY-DSD which does not have any genital ambiguity and manifests essentially in the pubertal age group with delayed onset or poor progression, and maybe even into adulthood in terms of infertility. There could be XY-DSD which presents really late, wherein you may have primary amenorrhea, inguinal hernia, the spectrum of CAIS, or you can have virilization at puberty. In an apparent male, breast development, cyclical hematuria, delayed or incomplete puberty could be the late manifestations of XY-DSD. So when we see a clinical approach as physicians or as caretakers, it is important when we meet a baby and a set of parents or caregivers to address the baby as your baby, the structures as phallus, folds, gonads, and not give a gender-specific terminology, which should be not used in our explaining the counseling these parents and older children when they're there. So when we speak of a clinical approach, we speak of, I have made this questionnaire kind of a thing, where you're going to find out whether first, is this an atypical genitalia? If this is indeed an XY-DSD genitalia, is it an isolated abnormality or a syndromic form? Are there any failure to thrive or growth affection present? Are the gonads palpable? Is the Mullerian structure present, and what is the karyotype? This could be one clinical investigative approach which is feasible in our country, in our setup, to go through to find out what could be the underlying cause or what could be the approach, what could be the underlying disorder of 46XY DSD. So these are the various male-looking genitalia which can manifest as DSD. Both gonads descended with a severe perineal penoscrotal hypospadias. Unilateral descended gonad with or without hypospadias. This child had a perineal single opening. Micropenis with both gonads descended. Micropenis with no gonads palpable. Or you can have a abnormal looking genitalia, more like a phallic structure, single opening and no gonads palpable. So phenotypic spectrum can be variations of any of these, and hence we should be able to figure out which are the developmental variants which may not be typically associated with a DSD. For example, a cloacal extrophy may not have a DSD underlying. A bifid glans, a very prominent clitoris, especially in an extreme preterm baby, epispadias, and vestibular cloacal anomaly with multiple openings. These are developmental issues and may not have an underlying DSD, and maybe we may not wish to investigate them much. So external masculinization score again has come in for a lot of debate, questions and research as to how could this clinical scoring system be used to predict or detect or define an underlying DSD. So how often are we correct in doing an EMS and we say less than 7 is atypical? And is this a good clinical correlate to order investigations in these children is a question to be answered. Looking for syndromic causes, this methylmiliopics, where you have a cleft palate, you have a digital abnormalities, and with atypical genitalia. There are other syndromes, like there is a list of syndromes which are standard given in books, but Pallister Hall, which is relatively common, Smith-Lemeli-Opitz, and your palmoplantar keratosis, sex reversal forms. So you have various genetic defects which can present with various associated congenital abnormalities. So looking at the brain, especially intractable seizures, presence of any hematological disorders, you have skeletal dysplasias, you have heart defects, coloboma, iris, post-axial polydactyly. So it's important to look at the whole baby or the whole individual to figure out is it a particular gene defect which can give rise to this syndromic form. So this is an algorithm which is made it's a very old algorithm made by Professor Gary Vaughan, but I think it still holds true for us in our country, especially when we do not have an easy access to the genetic studies. So when you say that SRY is positive and you have a uterus which is present, look at the LH and FSH. If it is high, you have a gonadal dysgenesis spectrum of disorder. But if the LH and FSH are normal, you have a spectrum of persistent Mullerian duct syndrome. But if the testosterone is low, and if you have an LH FSH which is high, it's either a testosterone production defect, which could be steroid pathway defect associated with cortisol and mineralocorticoid pathway, or it's isolated Leydig cell hypoplasia or a star deficiency, like it was suspected in the case that was presented. So there are multiple algorithms which are used, which are there in the for us to look at. But then I think final common pathway is go stepwise to assess the presence of Mullerian structures, the SRY gene, and then so on and so forth. So do we investigate all cases? No. Maybe some cases which need investigation as soon as they come to our clinic would be child with perineal hypospadias, absence of palpable one or both gonads, abnormal looking phallus, asymmetry of genitalia, associated systemic illnesses, family history of similar or other genital anomaly, or presence of extragenital features. So what evaluation can we do? Like it was beautifully presented in the case. The SRY now, I think, is easily available in many laboratories, and the turnaround time happens to be 48 to 72 hours, and it's within the reach of the common man, I would say. So that could be our first step of investigation, whereas karyotype takes longer, is cheaper, and somewhere it is even done for no cost. Presence of Mullerian structures to be seen by a trained sonologist would help, because presence of Mullerian structure in an XY DSD is more definitive of a dysgenesis related disorder rather than androgen synthesis or androgen action defects. The 17-hydroxyprogesterone anti-Mullerian hormone FSH and LH testosterone. Today, we do more often the 13 steroid panel, and in some centers, it is easily available. And in some centers where it is not available, it is within the reach of the patient and it doesn't cost much. So maybe 13 steroid panel, especially when you have a scenario of congenital adrenal disorder where you think of steroidogenous pathway defects, that would be more value for money rather than doing multiple tests like stimulation tests, ACTH stimulation test, etc. But genetic studies have put this in bold and a bigger font size because this is coming in more and more in use in terms of evaluation of children, not only with XYDSD, but I think across the spectrum of endocrine disorders, which are congenital and genetic. So this is just the number of 13 steroid panel which are done, the various metabolites which are checked. So this is a nice cartoon which came out, I think, in 2016 or so, wherein when you have a newborn screening with an SRY positive atypical genitalia, you could do the 24 hours, within 24 hours, a kind of metabolites or hormones. And then you may do, if it is an urgent test, it is always good to get an NGS molecular diagnosis and then do a reverse typing by doing the endocrine or anatomical evaluation. This is one thought which I feel today is better to do the molecular, or maybe we may need to develop more expertise there to develop the molecular diagnosis and then do the reverse phenotyping. I will go through a couple of scenarios. This 3-month-old baby who was growing well presents with this atypical form of genitalia wherein both the gonads are descended, well in size, nicely felt, and there is a single opening. And this is how the phallic structure is seen with glands, which is relatively well developed. So when we did his basal as well as stimulated, HCG stimulated testosterone, dihydrotestosterone, this was a nearly 10-15 year back kind of a case, wherein the ratio was supposed to be normal. The stimulated one was under 20 and the karyotype was XY with no Mullerian structures. So we did think in terms of androgen insensitivity syndrome in this case, and the child was given a gender of rearing, so on and so forth. Over the years, we have become a bit more cautious or bit more alert to figure out how to define this spectrum, which is the commonest kind of XYDSD that we see. Amongst the 50 children whom we evaluated between day 3 to day 14 years of age, there were 46% who were born small for gestation age, 16% who were born preterm, and 12% of these children were born of consanguineous union. There was a family history of genital ambiguity in about 12% of the cases, and 43, that means 86% of these children were raised as males, and 7 were being raised as females. And when we did the genetic analysis we did actually for 5-alpha reductase gene, we found that 58% of these children had some form of mutation abnormality. But then this PL86V, now we know is a variant and not actually a genetic defect, was the most common variant which we saw in our cases. But what we learned from this group of questions was the T2DHT ratio was not a very good predictor in terms of differentiating between 5-alpha as well as androgen insensitivity syndrome. So this similar study, which was done and published by Vandana Jain and Olaf and others from All India Institute, again, they found this PEAT-R246, which we also found in a couple of cases as the hotspot variant and a hotspot pathogenic variant in this scenario. So molecular genetic analysis should be considered as first-line test, as the T and DHT ratio lacks specificity and a hotspot variant is present in vast majority is what this group concluded. And we also feel that genetic analysis should in way complement or precede your T2DHT ratio related numbers. So there was this other study where they looked at 35 cases of 46XY DSD and had their, of which the androgen action defects were maximum. Androgen action defects were maximum. And when they did the mutation analysis by array CGH, etc., so they found that In 12 of these cases, a definitive genetic diagnosis was made, of which 9 were confirmed by clinical diagnosis and 3 needed a reclassification based on the clinical diagnosis. Something similar when we saw in our cases we just took isolated proximal hypospadias cases with both gonads descended. 65 of them underwent this evaluation, and 16 cases we could do the molecular study because this was not a funded one, and those who could afford that, almost like 1/4 of them undertook the genetic mutation studies, and 8 of them were abnormal. 6 had pathogenic variants and 2 had variants of unknown origin. So in our 65 cases where our surgeons normally say when it's an isolated proximal hypospadias, we do not need any endocrine evaluation. They almost always go ahead, do the repair and then refer to us sometimes a bit later also to see what is going on when the phallic structure is small, etc. So we ourselves found that 9.2% cases were genetically proven DSDs when they had presented with isolated proximal hypospadias. So the key message here is there is varying degree of virilization in children because of defect of androgen action. Mullerian structures would be absent in these cases, and EMS score and T2-DHT ratio do not always help in differentiating the underlying disorder, and often mutation studies are essential. So this interesting case, something similar like Divya was alluding to in the previous case, was a 2-month-old baby who presented to us in shock post-DPT vaccine, and she was found so dark, and she did have primary adrenal insufficiency. The genitalia were typically normal with 2 openings, though the labia seemed to be a bit underdeveloped. There was no clitoromegaly, as you can see here, and she did not have Mullerian structures on sonography. And then there were some vaginal echoes, and the karyotype turned out to be 46XY. So the learning which I had in particular had in such cases is when you have a normal looking genitalia and you think this is a female child who's come to you in an adrenal crisis, it is very important to look for Mullerian structures. That would be a good bedside clue to say if the Mullerian structures are absent, then it's not definitely a garden variety XX hypoplasia. You're going to look at XY, as in this case, this was a congenital lipoid adrenal hypoplasia due to star mutation. So don't forget looking at the ultrasound, doing an ultrasound in a child who otherwise looks normal and presents with adrenal insufficiency. And of course, the failure to thrive in a DSD, any form of DSD, especially here in XY DSD, points towards an underlying adrenal affection. I'm sorry for the spelling mistake. XY sex reversal with adrenal insufficiency should be ruled out in such girls is one of the key messages in this case. So now this last one, this was a very dramatic event. I think some of my colleagues might have seen these slides of mine. This is a very important learning curve for me. We were called intraoperatively for a child who was undergoing a hernia repair. So they had taken up the child for male child for an hernia repair. So where intraoperatively, when they were doing the repair, they found these Mullerian structures and they were very surprised, and we were called inside the OT and we said, just put them back. We will see what investigations to do. So this is sometimes a kind of presentation. So this was the uterus and both the gonads, and it was put back. This is how mine looked post this kind of intervention. He was growing well, developing well, and genital examination showed one scrotum empty and there was a gonad palpable on the other side. This is how the genitalia looked. So one learning here again we had was any child male child presents with inguinal hernia, it's important to see what is there in the hernial sac rather than going ahead with doing some definitive surgery. So sonography again would have prevented or would have led to more thoughts and maybe investigate this child prior to putting. So what this child had was a very high level of anti-Mullerian hormone and hence had got the diagnosis of persistent Mullerian duct syndrome. So one of the learning here is in a child who has a normal looking male genitalia presenting with hernia, do a scrotal ultrasound as part of pre-surgical evaluation to prevent surprises in the operating table. I think this is my take-home message. DSD is a medical and social emergency, and XY DSD is a heterogeneous spectrum of disorder. Like we saw here, some of them would have a complete sex reversal, and some of them would have just a isolated hypospadias, and the presentation could be varied, and problems could be due to gonadal dysgenesis, androgen synthesis defects, or defects of androgen action. Presence of failure to thrive points towards associated adrenal disorder, and that should always be kept in mind rather than putting it to nutrition and other issues, especially in our scenario. It's good to do an electrolyte and see if there is any electrolyte imbalance, which would invariably be there if there is an adrenal disorder presenting with failure to thrive because of mineralocorticoid deficiencies. Phenotypic sex guides the investigations, and it's always a multidisciplinary approach. And it's very important to take expert opinion and have a multidisciplinary team agreeing before those days are gone, and my friends, because it's not easy for any one of us to say this is what the diagnosis is. It's all, you need the surgeons, you need the neonatologist, you need the pediatrician, nephrologist at times. Meaning it's important for us to have a multidisciplinary approach in care of these cases. Thank you very much.
Thank you, ma'am, for the extraordinary session. So we all have learned some new things from your presentation. Thank you very much. We don't have any questions as such for now. Okay.
So it was a wonderful presentation by Dr. Sudha and covering the entirety of that. We have no specific questions overall at the moment, but I think it was a very enlightening presentation, Dr. Sudha. And again, thanks a lot for that.
The questions may come up.
Yeah.
I
would myself want to ask Professor Olof, as in the dilemma between 5-alpha and androgen insensitivity in terms of diagnosis is always very elusive. And I know the extremes of the spectrum are easy, but then when you have an overlap, when you have a phenotype which is, and the hormonal evaluation which is not really very clear cut, and the genetics gives you a variant of unknown significance, which often happens. So that's a dilemma in terms of diagnosis and assessment that we have.
So other thing that Dr. Sudha, from your talk, what we're looking at is probably genetics is the way forward, and biochemical evaluation is of not that much significant factors coming across many of the reports, not only from India, but internationally. So Professor Olat, what is your thought about whether we should ditch these investigations after the screening ones, excluding the salt wasting form, and go directly for genetics, or what will be the best way forward?
Well, we argue about that quite often. Good afternoon or good evening to all of you. Thank you very much, ma'am, for this wonderful presentation. I really enjoyed it very much. The difficulty is that, of course, hormonal measurements or endocrine labs are very, very different. So you need an extremely good lab, and especially for the differentiation of sex steroids, you would need a liquid chromatography mass spectrometry assessment. So the usually immunologic lab that's taken by some hospitals, or that's the usual hospital lab, is not sufficient to do these ratios, etc. So it would probably be wise, and this is how we discussed it in Europe, where you also have a very different approach in all our different countries, that we do it in parallel, because we will get, as you have said, and genetics is not the method that gives us proof for all cases. We do have a lot of variants of unknown significance, but sometimes we can correlate, and we heard this in the very nice presentation from Dr. Swathi, that if you take the variant of unknown significance and then correlate it related to the hormonal findings, then you have a most likely diagnosis. So we have actually said in our approaches that we do the things in parallel. It quickens the time to diagnosis, and it helps us making an accurate assessment.
So, sir, I want to emphasize on what Sudha ma'am was asking. So, many times the investigations, the genetic investigations turn out to be variant of unknown significance. And I myself tried doing a segregation analysis for a couple of patients. And, 50% of the times, one of the parent will be having a similar mutation. And they are phenotypically normal. So mostly they are heterozygous for that mutation. And then we have to keep on doing like a Sanger sequencing and all those things for that particular gene. So, do you think if we get if we are in a dilemma and we get a variant of unknown significant mutation, should we keep on evaluating or focus on biochemical investigation? So that's where we are in a fix.
Well, if I may answer again, it really depends on your resources that you have. We just took 20 years to elucidate a variant of unknown significance in an intron of the 5-alpha reductase gene. We will just publish it now. So that's not diagnostic, that's science and research. So that doesn't help us in our daily work. So really, at that point, we need to assess it. But when we did with Dr. Vandana and the AIMS people, the assessment of the ratio on 5-alpha reductase deficiency and the genetics, it came out that the genetics is helpful. And as you are in a country that has some hotspot regions, I think practically it's good to look for these hotspots and variants that are very well known. And then if you cannot go further, then of course you really have to think twice. And of course, as I know, also it has to be afforded by someone to do all these tests. Yes.
Yeah.
I think one question which has come up is very interesting is that in genetic tests now, with the availability of the next generation sequencing, we get a lot of clinical exome, whole exome sequencing in targeted panels. Generally, we've been saying that targeted panels have a higher depth of penetrance and they may be more reliable. So the question is whether we should go for any specific panel or we should go for a CES clinical exome or a whole exome sequencing. What would be your suggestion, Professor Olat, on that one?
Well, yeah, I can only answer again from the European and the German perspective, which I will go on to. And of course, we do the whole exome because it's not so expensive to sequence it all on the one hand. But then we look at certain panels, and if we discuss with Professor Zuta and you. There are only a couple or two handful of genes where we actually have management decisions based on these variants. If we have a variant in a rare gene, what information does it give us in clinical practice? Many times not, because we don't have any data that we can rely on, let's say tumor risk or whatever we will discuss later on. But I think androgen insensitivity, as we have heard, or 5-alpha or NR5A1, all those genes that were discussed already, they should be probably filtered through the exome as a panel, and then you can use those for management decision. Would you agree on that? Is that also your experience?
So sometimes the sequence of testing adds to the cost. So when you say you do a targeted panel and then you don't find anything, and then you say do a whole exome, and then it adds to the cost. So maybe is it wiser to just do the whole exome and have a VCF doing your bioinformatics on that, and then seeing if there is any if there is a variant of unknown significance, you can relook at the data and then see whether there are any particular. That's what we are currently trying to do, not in DSDs, but in scenarios where you're strongly suspecting, say, a child with, say, Prader-Willi or some such condition where you are not getting through the panel the desired results. We are getting that the data back, which is called the VCF, doing our own bioinformatics on that and see whether we are finding the reanalysis of whatever is being done. It's happening in-house, so it is less expensive in-house for us. But I don't know whether everybody has that facility. But I guess reanalysis is not expensive that much if you have a trained bioinformatics person with you.
And I think now the depth also is increasing overall in terms of the various panels that we are doing. So probably we are now shifting towards the era where panels may not be very relevant and we do the whole exome. That will be a good way to go forward because the depth is now quite increased. So I think this has been a wonderful discussion, and we will now move forward to the second aspect of the session. It is my pleasure to invite Professor Dr. Kaushik Urla, who is Associate Professor and Pediatric Endocrinologist at Katpurwa Medical College, Manipal. And Dr. Kaushik has been involved in multiple researches in terms of pediatric endocrinology in general and DSD in particular. He has over 15 peer-reviewed publications and is indeed doing a wonderful work at that field. So I'll take it over to Dr. Kaushik to carry forward the case discussion from here.
Thank you so much, sir, for the kind introduction. Good evening to one and all. So we have a wonderful case ahead, followed by much awaited lecture by Professor none other than Professor Olaf. So let us dwell into the thing directly. May I invite now Dr. Nimisha Sachin, Fellow Pediatric Endocrinology from Regency CDR Kanpur for a case, another case on XYDSD. Dr. Nimisha, you are there?
Good evening, everyone.
Yeah, you may proceed.
I'll discuss a case on XYDSD with my guide being Dr. Kaushik Urla, sir. The 2-day-old child presented to us with chief complaint of small phallic length and abnormally placed urinary orifice. On history of presenting illness, child was born to a non-consanguineous marriage with 37 weeks of gestation, birth weight of 2.7 kg, presented with small phallic length with testes present in bilateral scrotal sac, an abnormally placed urinary orifice with no difficulty in urination or urinary stream or straining during micturition. Negative history, no history of maternal drug intake responsible for abnormal development of genitalia. There was no history of abnormal genitalia in maternal uncle or infertility in maternal aunt. There is no history of any similar complaints in sibling. There is no history of any sibling death. There was no history of maternal virilization during antenatal period. There was no history of increased pigmentation noticed by the parents. There was no history of poor feeding, lethargy, seizure, or documented low blood sugar levels since birth. There was no midfacial hypoplasia, cleft lip, cleft palate, or club foot noticed. There was no complaint of any palpable lump in the abdomen. Coming to the antenatal history, it was a booked pregnancy. A mother took calcium and iron and folic acid supplementation. The child was born at term gestation with birth weight of 3 kg and cried after birth. There was no history of any neonatal admission since birth. Family history, there was no history of consanguinity between parents, no similar history of atypical genitalia in sibling, or no history of ambiguous genitalia noticed in maternal uncle, or no history of infertility in maternal aunt. On examination, the child was active, alert, with heart rate of 140 per minute, with respiratory rate of 55 per minute, with central pulses were palpable and peripheral pulses were well palpable. BP was recorded and was normal as per the age. Coming to the anthropometry, the length of the child was minus 1.08 standard deviation score as per the age, and weight was minus 1.3 standard deviation score, and head circumference was 0.79 standard deviation score. Doing the genitalia examination, the stretched phallic length was less than 1 centimeter. erectile tissue was present. Pinoscrotal hypospadias was present. The scrotal sac was formed with less rugosities. There was no asymmetry. Rounded structure with well-defined margin with volume of 1 ml were present, likely to be testis, as can be seen in the picture. On doing the external masculization score, the score was 6 out of 12, suggesting of undervirilization. On doing head-to-toe examination, there was no cyanosis, no cleft lip, cleft palate, no upturned nares, no syndactyly or polydactyly. Systemic examination was within normal limits. There was no palpable lump in the abdomen. So we came to the differential diagnosis of 46XY DSD, either due to testosterone synthesis defect, which could be due to 17 beta HSD deficiency, or LHCG receptor defect, defective testosterone conversion due to 5 alpha reductase deficiency, or defective androgen action, or gonadal dysgenesis could be the possibility. CAH, like 3 beta HSD deficiency or 17 hydroxylase deficiency was also kept as a possibility. And ovotesticular DSD and 46XX testicular DSD were kept as a rare possibility in this type. On investigating at day 3 of life, there was no hyponatremia or hyperkalemia noticed. Testosterone levels were high. AMH level was high, and DHEAs was more than 1500 microgram per deciliter. Karyotype of the child was done, which was 46XY, and before that USG abdomen was done, which was suggestive of no Mullerian structures. On follow-up, after 2 months, the weight gain was present. The phallic length increased to 1.5 centimeter. There was no hospital admission or no dehydration noticed till now. There was no hyponatremia, hyperkalemia again on investigation. LH levels were high with high testosterone levels suggestive of mini puberty. On narrowing a differential diagnosis due to normal testosterone.
If I can interrupt, just go back to the previous slide, just for the understanding and to bring the discussion. Can you just tell us or enlighten us about the utility of mini puberty as well as AMH in the diagnosis of 46XY DSD? Because we are dealing in that. It's a because the child presented at 2 months and you followed up at 2 days very early, and you followed up at 2 months. And we can see a good LH of 8.97 international units per liter, which suggests mini puberty. Can you highlight or tell us the utility? How can we clinically use this mini puberty for the diagnosis of XYDSD as well as role of AMH in diagnosis of XYDSD?
Yes, sir. AMH, high levels of AMH was suggestive of that there was regression of Mullerian structures will be absent. The role of mini puberty in this case was that we will look at the LH levels and testosterone levels, and if they will spontaneously increasing the phallic length or not will be helpful in deciding the action of testosterone will be there or not.
Yeah, to add to what you have said, it's not just absence of Mullerian structure. A good AMH in a suspected XYDSD is reassuring that it is not dysgenesis or less likely to be dysgenesis, even if it is, it just tells the Sertoli cell functionality. So a good AMH is reassuring in not dealing in terms of dysgenesis. That is one thing. Secondly, coming to mini puberty, one thing is clinically, if there is a phallic length involvement increment during mini puberty, testosterone is acting, that's true. But more than that, or along with that, what I would say is it's a period where you can utilize it without stimulation. Otherwise, if you want to do some tandem mass spectroscopy and mass spectrometry for diagnosis of hormonal panel, as we discussed earlier, you have to give beta HCG, you have to, it's a tedious process. It involves invasive injections, where this mini puberty period from 1 month to 6 months, if there's a clearly documented pubertal LH, you might straight away go ahead with your concomitant or sequential hormonal evaluation. So this is a room for clinician to utilize whenever possible without any invasive HCG stimulation. Yeah, you may proceed.
Yes, sir. On doing the differential diagnosis, The high normal testosterone levels ruled out the testosterone synthesis defect. The conversion defect hold on a possibility of 5-alpha reductase deficiency was there. The partial androgen insensitivity was kept as a possibility. 3-beta HSD was kept as a possibility, rare although, and the high AMH level ruled out gonadal dysgenesis, and absent Mullerian structures ruled out ovotesticular DSD, and karyotype of 46XY ruled out 46XX testicular DSD in our case. So we straight away moved to the genetic testing, which was suggestive of SRD5A2 mutation, likely to be the compound heterozygous. And the final diagnosis was 5-alpha reductase deficiency in our child. Coming to the management, the sex of rearing was kept as a male, and there was a plan to look at the phallic length size post puberty, and if it is still small, the plan was to start DHT gel, which is given in a dose of 0.2 to 0.3 mg per kg per day, applied locally in 2 applications per day, and duration is 3 to 6 months or till the appropriate size is achieved, and staged correction of hypospadias and chordee. Talking to the implications of 5-alpha reductase deficiency on puberty, future fertility potential, and gender identity development in the patient. Due to increase in testosterone levels during puberty, there is seen that muscle mass, voice change, and phallus length increase spontaneously in puberty. The scrotum hyperpigmentation, and there is increase in rugosities as well. There is no erectile dysfunction noticed. Descent of testes, if present in inguinal region, occurs during puberty. And high dose testosterone treatment improve virilization, self-image, and sexual performance. However, there is no clear-cut consensus available on use of high dose testosterone during pubertal development. During an article published in Pediatric Urology in 2021 suggested that exposure to androgen influences the gender role development in a child as male, and those who were reared as female, 50% of them virilized at puberty and requiring the change of gender. Therefore, according to this article, the GID prevalence was 53% in 5-alpha reductase deficiency. A similar article published in the Pediatric Urology on fertility potential in 5-alpha reductase deficiency showed that oligospermia and presence of azoospermia in these children due to impaired spermatogenesis, either due to 5-alpha reductase deficiency or presence of cryptorchidism. And there is a requirement of artificial reproductive techniques like IUI, IVF, or ICSI for fertility options. Therefore, the key messages in my case would be stepwise clinical approach to DSD. The evaluation of hormones in mini puberty plays a significant role in diagnosis with interpretation and guiding clinical decision making. Correlation of clinical findings in biochemical picture. Genetic testing is the modality of choice after initial biochemical workup, and early child-centric multidisciplinary counseling considering future puberty, gender identity, surgical possibilities, sexual life, and fertility are the key planning and decision making in this case. Thank you.
Yeah, thank you so much, Dr. Nimisha, for that clear-cut and simple presentation. It was very nice. So I wanted to stop you when you said, mini puberty, we did testo was good, and there is a phallic length enlargement, and we straight away jumped to genetics and ditching the biochemical evaluation. But from experts, madam and sir, we heard just a while ago, whether it should be other way around, biochemical evaluation followed by genetics, or other way around. It's a big debate. In my limited experience, what I would say at the end of this case is you are very fortunate that you clear-cut got the compound heterozygous and known mutation in the known gene causing a clearly explaining the phenotype. So you are saved. But we know, and we have learned from the experience of all seniors and large publications that in XY DSDs, especially the even in the best of the genetic labs, the yield or the output or the positive results is around 40 to 50%. It may sometimes, if the region has a hotspot mutation, it may go up to 60%. Otherwise, in remaining 40%, you are still stuck. So in such 40%, which is not a small number, in our clinical practice, at least it's very important. we have to be mindful that, maybe as Olaf sir said, many a times, if there is no resource constraints or, if accessible resources are there, fortunately in our country now, TMS is easily accessible and affordable to many of the centers nowadays. That's a good thing in our clinical practice. So maybe a concurrent evaluation may be required is what I would personally say. One question before to you before we open the session for expert comments is, what is your comment about or what's your reading about utility of DHT cream pre-pubertally or post-pubertally? You said during mini-puberty you would give, it will increase the phallic length and allows the surgeons to do a better job. So what's your take on pubertal DHT or peripubertal DHT?
Sir, many articles have shown that already increase in level of testosterone levels during puberty increases the phallic length to the appropriate size. Still, if it is low as per the age criteria, we can try a DHT gel application in them.
Okay, yeah, I agree with you. DHT gel application also increases the DHT level in the blood as well as some virilization. But we know at the end that, phallic length increment even after DHT application sometimes may not be adequate or as we expect. I would like to hear from Sudha madam and Olaf sir about their experiences in pre-pubertal or peripubertal age group about DHT application. We know that DHT is not very easily available, but still of late we are getting a decent DHT supply. I would like to hear from madam and sir.
So as far as Indian perspective goes, I'm sure all my colleagues here also experience the same way. One, it is a very expensive drug. So it costs almost like 10,000 rupees for a tube, which is for 10 grams or something. So, and how to apply, how much to apply, how frequently to apply. I don't know whether we have any dose regime given there. So it becomes very arbitrary to apply. That is one. Two, the response is also very anecdotal. So I do not have any strong voice to say that yes, use DHT. That would improve the phallic size. I don't know. I would like to hear from Professor Olaf and Anurag.
Well, I completely agree with you because we used to use it in the early days, but now our surgeon doesn't like it anymore because he says the vascularization is stronger and the bleeding at subsequent surgery might be prolonged. So there's a surgical reason. There's a, let's say, more philosophical, biological reason in that you have a certain, let's say, preset phallic length, and you're just, let's say, taking something earlier that might occur later. And third, I talked to the company that in Europe actually manufactures DHT. That's the company Berzons in Belgium, and they had contacted me once to do clinical trials for micropenis, and at this stage you cannot do any clinical trials in this. So we don't have any evidence on the, let's say, really good success of DHT cream. And as you will hear later, I'm rather very cautious about doing these things in young infants. So I would agree with about this.
So what about high dose testosterone, sir? High dose testosterone.
Even less, because in a young infant it's unphysiological unless in the mini puberty, but then of course it's LH-FSH driven, and of course due to the aromatization you might get a subsequent acceleration of bone age. So that's why I wouldn't give testosterone either. And if you do that, if you give the exogenous androgens, usually you see other effects which you usually don't see during mini puberty, like pubic hair, etc. So you get an, let's say, unphysiological virilization of these infants, and that's why I'm also very cautious. I don't know what your experience is, but these things have made me very cautious.
Sir,
You
I
know,
was
it's
asking in pubertal age groups, sir, like pre-pubertal, if the surgeons want to do corrective surgeries, late diagnosed cases.
Well, in pubertal children, it might be different. I'm currently following 2 adolescent young adults with 17 beta HSD deficiency, so conversion defect of androstenedione to testosterone. They do synthesize testosterone, but you might need to enhance that with further testosterone. And the same holds true, for instance, for Klinefelter. We know that if you have a lack in testosterone at the time of puberty, you might use testosterone to enhance that. That's a different question. So one is the infancy question where I'm reluctant, and the other one is the pubertal, where I'm more in favor if the gender assignment is stable.
Okay,
So
sir.
Dr. Kaushik, just to highlight, because we've been managing this case for the last 2 months, so we did see a very good response to the spontaneously high level of testosterone in the initial phase. But even he came, I think, a couple of days back again, and still the testosterone was reasonably high, but there was no response further, which means that you need to have a very high level of testosterone for it to be effective, probably in the tune of around 200 nanogram per DL and above. So that is something which will be too difficult to achieve via a simple injection, and you will need a much higher dose. Just coming back to the protocol of evaluation. So what we have thought of, and we have been reviewing XY-DSD maybe 20 years ago also, with all the biochemical tests, the yield was around 30 to 40%. And even there, many of them, when they were doing genetically, it was found to be wrong. So now what we are probably sticking to is that if we have a clear-cut case where the testo is above 100 nanogram per DL, which means that there is not a significant biosensitive defect, there is no salt wasting, and there is good AMH response about 20, and there is no Mullerian structure, which pretty much leaves us with 2 major differentials in terms of 5-alpha versus a partial AIS. We stick to go towards the genetic diagnosis rather than sticking to the DHT levels. And we have found that because many of our cases also turned tables once we got the genetics. So we are now moving into that genetic part. Yes, after demonstrating a good AMH response, a good testosterone response, lack of salt wasting, and no Mullerian structure. That is the thing that we are thinking following up in that regard.
Thank you, sir. Thank you so much. So it was a very good discussion. Any questions? I'm just looking for any questions. No, I don't think we have any question. Probably, yeah, as Professor speaks, maybe we can expect some more questions. So going ahead with the next and the most awaited part of today's evening is lecture by none other than Professor Dr. Olaf Hjort. Sir is a great teacher, teacher of teachers. I know for the pediatric endocrinology community of India, he doesn't require any introduction because we all know him, we all hear to him and learn from him all the time. Sir is board certified for pediatric endocrinology and diabetes, neonatology and laboratory medicine. Currently, he is chief and heading division of pediatric endocrinology and diabetes, Luberg, and also his pediatric chair, European Reference Network for Rare Endocrine Conditions, also speaker in Collaborative Research Center, Sex Diversity, funded by Dutch, and he has more than 275 publications listed in PubMed to his credits with a H index of 66, and all these things just speaks about sir and his contribution to the field of DSD. I feel he is most deserving to talk and enlighten us in this evening about the management of 46XY DSD. Sir, over to you.
Oh, I thank you very much for this introduction. I hope you can now see my slides.
Yes, sir.
Just
Very
give me a
much.
hand up if
Yes.
that's possible. And I have to say I'm very honored to be invited to speak to you, and I give back your nice words because I've been enjoying so much talking to Dr. Suta. You had a lovely talk, and I think we had many beautiful discussions. And I'm thankful to all the speakers, especially the fellows, for the presentation of these interesting cases. So what I'll do this evening is not giving you a cooking recipe. Just everybody listening, I think we all know, and it has become clear from the discussion points already, that there are no, let's say, cooking recipes. If this is the case, do that and that's it. What I will do, and hopefully I can go to the next slide. Let's see. I have no disclosures. There's no money to be earned in DSD. Let me tell you that. But I will remind you that, of course, as we had heard from Dr. Suta, there are many heterogeneous manifestations of 46XY. That's why there is no cooking recipe. Of course, you have the newborn, which you have heard from the cases with the genital ambiguity. There may be a clear-cut male or female genitalia, but you have a discrepancy to a prenatal NIP test, as we call it, so prenatal chromosomal analysis or something like that. Or in our parts of the world, and many greetings to all of you from Europe, we have a lot of screening by ultrasound of fetuses, and then you have a discrepancy. So this might lead you to further diagnostics. And of course, as you've heard, you might have syndromic findings, and that leads to a completely different pathway. However, sometimes we see inguinal hernia and the findings, as we heard in the patient with a Mullerian duct abnormality, the persistent Mullerian duct syndrome. Inguinal hernia may be a case of manifestation or an acceleration of development with very early puberty. And of course, you have the adolescent and adulthood, where usually the patient is already very much fixed in a gender assignment, but you suddenly have an atypical pubertal development with gynecomastia, abnormal virilization or virilization deficit. So if you see all these different types, of course, you would have to find a pathway for each clinical finding in order to see what you do. So whatever you have seen as a clinical manifestation, you have to reflect what you are doing. And this is the essential part of my presentation at the beginning in the first few slides, because of course we all think if we have a typical, either on the left, a female manifestation of the external genitalia, or a male manifestation as seen on the right-hand side, there is, of course, a pathway from the medical biological way that you don't have to think too much about the gender assignment. But what do you do if you have intermediate genitalia that look like this or look like this? Do you go by eyesight? Is it really feasible to go just by the genital aspects? I will challenge that and show you this picture. And on the left-hand side, you see a sign which probably some of you know. It's the gender-bread person that is used by gender identity advocacy groups. But it shows us a little bit that, of course, you have the sex on the sex, which may be ambiguous or be alluded to the male or female phenotype. But think of DSD as a condition which affects the whole body. And in this regard, of course, the whole body expression pattern will be affected in later life. So if you see somebody, of course, you see the muscles, you see the skin, you see the whole body affection. And this is something that also is, of course, something that affects the later gender assignment, etc. And of course, also the identity of a person may be completely may not match the phenotype of the external genitalia, but is this thing that is, of course, something that only an older person can tell us what the gender identity may be. And lastly, of course, we have no idea of sexual attraction, etc. And one idea, and this is why I'm showing it, is that you have a very differential expression of body sex in a person with DSD. And the example is complete androgen insensitivity, where you do have an XY karyotype person with a normal testicular development, normal in brackets, because it's not normal. I can show you that from many research examples that we have now. But the hormonal profile is, of course, interesting because you have high doses of testosterone, and you also have the AMH secretion that we just heard by Dr. Kushigurala that leads to the suppression of the uterus development. On the other hand, of course, the testosterone cannot work. And this means that the external genitalia development will be in the female pathway, meaning you have the two openings, so you have a urethra and you have a vaginal development. Of course, due to the expression of the external phenotype, you get a female body shape. And in many of the people, you have a female gender identity, and they also take a female gender role later in life. So it's stringent that we not only judge people by the external genitalia phenotype, but that we have a prognosis of how the whole body expression will do in later life. So in my talk, I will touch on 4 different aspects of DSD or management of DSD. One is the management of the gonad. The second is the assignment of a gender category, so male or female. In my country, we have even more categories, I think in your country too. The management of the sex characteristics, meaning surgery or whatever you want to do. And lastly, of course, and that's a self-reflection, is how do we monitor the success of our management? What is there about quality of care? So let's go to the management of the gonad. And what you have to judge upon is, of course, the risk of tumor, which often we as medical people judge extremely high because tumor risk assessment or the tumor risk has always led to the possibility of early surgery, removal of the gonad, etc. But of course, this is something that has to be weighed against the endocrine functionality, and of course, in some diagnosis of DSD also on the fertility options, because of course this depends on the diagnosis, as we have just heard for the 5-alpha reductase deficiency, because in 5-alpha reductase deficiency you might have the option of sperm development. So if you opt to take the gonads out, you will severely alter the patient patient's perspectives. Of course, it also depends on the age. For instance, in the complete androgen insensitivity syndrome, we have altered our assessment in this regard, in that we say we don't take the gonads out during puberty, but we leave them in, and we try to see how this patient will develop during puberty. And lastly, of course, whenever you discuss these options, you have to take into account the personal risk of the patient. What risk are there to take for the patient? How do they, the patients or the parents, react to this risk assessment? And what are their needs? How much do they understand what you are talking about? About this management of the gonad, I have put in two examples. On the left-hand side, you see the complete androgen insensitivity syndrome. And as I've said before, the endocrine function of the gonad is often very good. So they produce high amounts of testosterone, and they go through a rather typical period of puberty. Their fertility option is often always negative. I've never seen any gonad that really has intact germ cells that you could retrieve for fertility options. The tumor risk is currently reassessed because I think the rather malignant point of seminomas or germ cell tumors is probably much lower than we have previously thought. What happens in these gonads is that they have a very particular way of producing the steroids. I will show you a little bit about this in a moment. And due to these pathways, they develop Sertoli cell or Leydig cell adenomas. And these are benign tumors, which we see. And currently, I think we are in a stage where we cannot assess these particularly well. We need much more research on this, because the question is, do we have to take the gonads out if we see these kind of tumors, or how do we make a diagnosis of these tumors? We haven't talked much about SF1 or NR5A1 mutations, but I think most of you will know this diagnosis. NR5A1 is a quite often affected genetic mechanism of producing 46XY, sometimes very rarely of 46XX DSD. And in these patients, the endocrine function may also be good. I'll show you it's very particular in a fashion that NR5A1 leads to a very special form of gonadal dysgenesis. The fertility option is also very low, and most likely from the data that we have from the databases, the tumor risk is also rather low. And I'll show you a little bit about the endocrine function. Please have a look at the left-hand panel of adult patients with complete androgen insensitivity. And what you see are the black boxes show you that the LH levels on the upper panel are rather high, which we know. The gray shaded areas below that depict the usual reference values of female and the typical male people. And on the right-hand side, you see that the FSH levels are in these typical ranges of normal females and males. And we can probably use these assessments to say how much the Sertoli cell and Leydig cell apparatuses are functional in these patients if they are within these black boxes, because this is normal. And what you usually see on the lower panel on the left-hand side is that the testosterone levels are within the typical male reference ranges, and the estradiol levels are rather low for females, but within the upper range of the male reference ranges, which is a very particular finding. And if you have these ranges, then you can assess the endocrine function as quite normal. On the right-hand panel, you see values of children and adolescents with NR5A1 mutations. These people usually have rather severely affected genital ambiguity at the time of birth. And when we assess them in the early age, as you see in childhood, in the upper panel, you see the inhibin B, which is reflective of the anti-Müllerian hormone. You see that these values are very low. Which makes a diagnosis of a partial gonadal dysgenesis. But what we saw when we followed some children through puberty is that the testosterone values were rather high. So you have a discrepancy between the Sertoli cell function of inhibin B and possibly the Leydig cell function of the testosterone. And this shows us that in these patients, we should not judge according to the external genitalia status or according to the inhibin B status, but that we have to follow them throughout puberty, and that in many of these patients, you have a quite strong virilization throughout life. The testes or the gonadal development is something very, very interesting. I'll show you a few of our research data because the testes, and this is a picture that my daughter drew. She's a medical drawer in her spare time. She's actually a surgeon by education. And as you all know here, you see the Sertoli cells, you see the germ cells. So the testes is a very let's say, orderly organ, if you see it develop. And look at the Leydig cells, so between the tubules here on the left-hand side. So this is a typical testis. And we always think that the Leydig cells produce the testosterone and the Sertoli cells produce the fertility apparatus. But that's not the case. There's also a developmental aspect, and that to reach the status of a fertile, fertility-producing testis, the testis develops and does something in the testosterone biosynthesis, which is very peculiar. I'll show you some data from Mustafa Al-Shakawi, who's currently a postdoc in our lab, and he's coming from Cairo, from Egypt, and last year he defended his thesis where he looked at the gonadal tissue of XY individuals. And on the left-hand side here, you can see again how testosterone is produced, and you see different enzymes. And in yellow, you see on the left-hand side the CYP17A1 enzyme, which we have already talked about in the first case presentation by Dr. Swathi. And you see on the lower panel the HSD17B3 enzyme, which is the last enzyme to produce testosterone. In usual cases, if you look on the right-hand side, you see an immunohistology from a normal testis on the upper hand panels, on panel A and D. And on the lower panel, you see the gonad of a patient with complete androgen insensitivity, also in late adolescence. And the CYP17A1 enzyme is expressed in the Leydig cells. Remember, they are between the tubules. The tubules in complete androgen insensitivity are smaller. The upper panel of the adult normal male testis. So these enzymes are produced in the same cells. If you look at the late enzyme, the HSD17B3 enzyme, it's expected in the normal testis to be produced, and you see that in the brown coloring in the Leydig cells. However, in the complete androgen insensitivity gonad, it's produced in the Sertoli cells. look at the lower panel and you see the brown coloring in the tubules. So the testosterone in complete androgen insensitivity syndrome is actually produced in Sertoli cells. And this may explain the formation of Sertoli cell adenomas. And this was what I was telling you, that we have to rethink how the gonad in DSD is functioning, and this may lead to a different assessment. If we go to the next slide, let me see, where's my next slide? So here we did many of these experiments by now, and here you see the normal test is on the left panel, and you can see that all the enzymes are produced in the Leydig cells. In PAIS, so in a gonad in the middle, where the androgen insensitivity syndrome is not complete, you can see some areas which probably, and on the right-hand side, you can see that also, where probably Leydig cells are also producing testosterone. So it's a mixture. And then you get these Leydig cell, Sertoli cell adenomas. So the malignant part may be much slower or much lower than we previously thought. So then we went on and looked at data that are commonly available. These are data from single cell sequencing. This is, let's say, fetal tissue or tissue throughout lifetime. And what you see here on the left-hand side is this enzyme HSD17B3. That's the one that we usually typically associate with testosterone production. And on the lower panel, you see AKR1C3. That's the type 5 isoenzyme of the 17-beta HSD. And what we see from these data is that the fetus actually produces the HSD17B3, so produces testosterone through this enzyme. But if you look at the later life and you go through the pubertal and adult ages, you can see that the adult person, so us, so to say, we produce probably testosterone through another isoenzyme, which is seen here in black. And you can see on the right-hand side that the enzymes are differently expressed in the different cells of the testes. This explains, for instance, why patients with 17-beta HSD3 deficiency virilize at the time of puberty, because they express the isoenzyme AKR1C3 in adulthood or in puberty in their Leydig cells, and this is the way they produce testosterone. Same holds true also for 5-alpha reductase deficiency, as we just saw. There is an isoenzyme that takes over at the time of puberty, and this is why you will then see why you see the virilization of these patients in due course. So coming to the end of this part, the option of management of the gonad is weighing the options. Tumor risk may be high in certain types of 46XY DSD, for instance, in the Fraser syndrome due to WT1 mutation. There's no doubt you have to take these gonads out. In the others, please take an assessment, very individual, as I showed you, from diagnosis to diagnosis, surgery risk versus functionality. If a functionality is possible, for instance, in 5-alpha reductase deficiency, in partial androgen insensitivity, you have to take a decision at the time of the first birthday, because there are strict consensus guidelines that you have to take testes down into the inguinal canal or into the labioscrotal folds to keep up this later functionality. And then, of course, in CAIS and NR5A1, retain the gonads, keep them if possible. And lastly, we don't have any guidelines yet for the preventive examination measures, how we go about if we keep the gonads in DSD. We really need a good consensus guideline for this in the future. The next point that I want to make is the assignment of a gender category. Please be reminded you can assign a gender. That's the way people work during their lifetime, but you cannot assign a sex. A sex is there, as I told you. It will develop. And this was the mistake that possibly the older founders like John Money did in the last century, because they said, okay, you have to assign a gender role for somebody to be part of our societies, but you cannot change the sex of a person. That's biology, and biology cannot be changed. You can change the look of a person, but you cannot change a person's sex. So what can we do? I think the decision should be based on a medical diagnosis, as we heard earlier, and on the prognosis, as we heard very nicely by Professor Zuta. But I think ethically, and this may account for India as well as for Europe, you have to leave as many options for the affected person as possible to make informed decisions about their life later. And this makes it so extremely difficult to make decisions for an infant, because we don't know how that person will decide later in life. And of course, then comes about in the newborn, what do we want? And of course, you know that parents want the best for their child, so they want you to make decisions. They want their child to be secure. They want it to be happy. And of course, they want this child to be fertile to bring about grandchildren later. So every parent wants that, be it here in Germany or in India. And of course, they want their child to be a boy or a girl. So they want a decision from you. Then we are stuck, because we as medical people, we have to assess. As we heard, there are syndromic cases, there are very severe cases of adrenal insufficiency. In those cases, we have to act as a medical person. But in many children with DSD, we do not have a life-threatening event. So it's more psychosocial than a really medical emergency. And we have to react to the parents' shock, anxiety, and sadness, and to react to their disruption of their family dream. So we have to counsel them about the future of this child, and we have to also take into account that we, of course, know many of the issues, but they may not. They may have never thought of the biology of sex development or the medical background of this. So the question that you have to parents is that you have to counsel them. The child may not have a big problem in this stage of life, and this makes the parents the patients. It's not the child that's your actual patient, but it's the parents that are your patients. And this, I think we have to reflect most often, because I think in the early days, and many of you remember that, we took the child and treated the child in order to get rid of, or to really treat the parents. And this is something that's a discrepancy in pediatrics that we encounter in many cases, but it's the essence of pediatrics. So in Germany, we have made guidelines, and we have heard it from Dr. Suter that, of course, the multidisciplinary team is there to counsel the parents, but also to counsel within us, because we have such difficulty in doing this. The team mandatorily needs a psychological support. We take in peers at some point, people who have a condition, because it makes it easier for parents to understand that there is a continuous life. So if you have something like that. And of course, we have to follow the lines of the diagnostics. We already talked about the experienced labs that we need, and we need case conferences like this always to reflect the better management. The management of the sex characteristics. So surgery, reflection of hormonal therapies is a big debate. I can only give us food for thought. Don't only think about the, let's say, the phenotype of the primary sex characteristics, but as we discussed in the use of topical dihydrotestosterone, think about the effects on the whole body sex. So if you do something, do a reflection, what do you do on the whole appearance of the person? Because this is usually how somebody appears in public. They don't appear with their primary sex characteristics, but they appear with a whole body appearance. So differentiate between the sexuality aspects, the fertility aspects in the future, and of course take into account, and this is where I'm just a guest in your country, the cultural and societal beliefs, which are very different in all societies. But we are also a very heterogeneous country now with many migrants from your continent, etc. So we have, this is why we have to talk also, because I'm learning from you. What are your beliefs and how does it work? There's one thing that I want to do, and there's something that I want to point out to all our listeners. We in Germany, we had a statement of the German Ethical Committee, which is a committee which advises Parliament on very difficult positions. And they wrote a very interesting book on intersex, and it's also available in English. So if you want to read it, please use it, because I know that in many parts of your country, for instance, in Tamil Nadu, you have courts, rulings, etc. So there is a big discussion also in your country on the ethical side. And the major thing of this is, of course, avoid discrimination of people. Try to create the centers of competence that work in the way we just discussed, which needs interdisciplinary work, which needs expertise, which needs educational levels. And lastly, of course, put the patient into the focus with treatment possibilities and avoid irreversible treatment if you can, to leave the options open for that person. It's available in English, and it's interesting to read, even after 13 years. We have discussed a lot about this multidisciplinary team. I will not go into this because it depends on your possibilities. We have already discussed it. Labs may be difficult to find, or genetic possibilities may be difficult. Every center should have its own way of dealing with a multidisciplinary team. The only thing that I would like to point out is that it should not be one person after another, but a multidisciplinary team should work together. So it needs like the overlap of these different bubbles. So it's not one person after another. In the Chicago Consensus Conference 20 years ago, we said this is mandatory to work together. And we have published many papers on how to relate information to the patient, how this can be done. I think the management includes the inclusion of the patient age appropriately to convey all the information that we have to parents and patients in a way that they can lead the life they want to lead and that they're able to lead. Lastly, I want to go into the quality control because, of course, we as centers need to judge. We need judgment if we are good or if we are doing what we are supposed to do. And this is the scale of Germany. We have 16 different states, as you can see, and I've put in the purple things. These are centers in Germany that have certain quality agreements on the European scale. They are so-called endocrine reference centers on the European level. level. And you can see Lübeck is up in the north next to Kiel. We are one hospital. Berlin is on the right-hand side. And we are matching with the red ones. Those are centers accredited to a urological scale on the European level. And we have a registry, which is very important, which is the green thing. And we are working together with patient advocacy groups, and we are trying to assess ourselves according to quality indicators, which we have just published. And there are certain criteria for quality indicators, meaning structural things like how many people do you have who have a certain qualification, etc. There are process quality indicators, which means how is your way to a lab? How do you reach a diagnosis? And of course, certain quality criteria for outcome, which means that you have to send questionnaires to the people and ask them, how do you feel? How was the clinic visit? Did you get the information you wanted? Yeah, how's the outcome measured? Is it just a measure of, let's say, do they come back? Did they agree with the procedures? And of course, we also need long-term outcome for many reasons. So this is something that I think we always have to discuss around the world. How do we define quality? My conclusion is I think that management of XY is a big challenge. There are no cooking recipes. It needs a very personal assessment and a quality control. I think biological research, I have given you a glimpse of what we are trying to do, is that it's not, let's say, textbook knowledge. There are many new insights into gene expression patterns, regulations, which shows us how complex sex development is. And this, of course, needs to be matched by clinical trials and clinical assessments, because we need good outcome to provide the healthcare management to these people. And in order to a broader consensus on how to manage these patients, I think we need to include our societal sciences, which is a very different approach. What is gender? How do people move in our country? How is sex and gender seen? I think we are all currently stunned by the way America is doing this, and the US, how this is done in the sports world, etc. So I think there's an ongoing discussion which may be very political. What we are currently doing in Lübeck, in my hometown and university, is we created a collaborative research center which currently encompasses a lot of researchers and a lot of scientific approaches in how to define determinants of sex in different scales of biology, medicine, and also the social cultural environment. If you are interested in this, there's a website which I show you in a minute. Next year, we will have the so-called IDSD symposium here, and also the postgraduate course. If you are interested in that, please find us on the internet, and we'll find more information. And I hope to see some of you here in Lübeck. This is actually the team of the Collaborative Research Center and the website with much of the information. And I hope to tell you more about this in the future. Thank you very much for your attention and for having me talk. Thank you very much.
Thanks a lot, sir. Thanks a lot, sir, for your insightful and thought-provoking lecture. As you repeatedly said, no cooking recipe, and cutting the clutter when it's impossible when it comes to XYDSD. But definitely you gave a lot of food for thoughts. As you know, we are a very heterogeneous country. A proper, structured, experienced, multidisciplinary team, focusing on the longitudinal outcome of the child, keeping the child in the center rather than society or the parents, is the need of in our country too. Hope with ISPAE and all seniors advice and ongoing teachings. Probably we are heading towards that long route. Thanks a lot once again, sir, for your great lecture. Waiting to hear you in ISPAE conference too. Thanks a lot. There are no questions, I believe. As of now, there is no questions. Anurag sir or Sudha ma'am, anything?
It's always a pleasure to listen to you, Prof. And the insight into the molecular aspect and how to put that into clinical practice is something which has been always awesome ever since I've known you. And XYDSD, the concept of getting 5-alpha versus AIS, the thought-provoking approach was entirely because of your work at All India Institute. It's a pleasure to listen to this. I'm sure there are still multiple answers, and we can have a whole day CME on DSD and listen to you and other experts talk only on DSD. Maybe we should now go more from a general endocrine conference to have only a DSD conference where we can maybe segregate the nuances relevant to our country and maybe take help from them to streamline that process.
Madam has already conducted a national level conference last year. So thanks a lot, madam.
Yeah, maybe, yes.
I see one question about a DSD committee legal requirements in an Indian setup. There are two aspects to this. One thing is, of course, we don't have a legal requirement to do the multidisciplinary team and the quality control, but I think we have an ethical commitment to this. Legal requirements are popping up in many countries, especially in Europe, and I don't know, in Germany, we have a law since I think, or for 4 years, I would say, that restricts surgery in infants. Genital surgery in infants is restricted, and this means there is a committee. We have to form a committee to argue if we want to overcome this law, to, for instance, to do hypospadias repair in a child. Of course, you can say, wow, how can law restrict me as a medical doctor? But on the other hand, my feeling is that it has led to a much better and thoughtful approach to the patients, because as you also, Professor Sudha, said, there are people, surgeons that just operate. I don't want to bash surgeons here, but we all know that. This way of acting according to legal requirements has led to a very thoughtful approach by the surgeons, in that they incorporate us before they do surgery to find out a diagnosis like you presented in your case with persistent Mudarian duct syndrome. So in essence, there are lawmakers now that push us towards a better quality control, but we should take the action again and do the quality control before the lawmakers take care of this. I hope that answers the question.
Yeah.
And greetings also to Dr. Rajni, who also put a post in the chat. Thank you.
Thanks.
Over to Anurag, sir.
Thanks a lot, everybody, for this wonderful session. And we have really enlightened about XYDSD. The enigma has always been there, but probably with the availability of newer tools in genetics and newer developments, this thing is, the mist is clearing out gradually, but still it requires a multidisciplinary and a multi-pronged approach. I'd like to really thank Professor Olat, Professor Sudha Rao, Dr. Kaushik, Dr. Divyalakshmi, Dr. Swati, and Dr. Nimisha for making this session really wonderful and interactive. Hearty thanks to Jhalak, who has been instrumental in doing the ACES program for the last few years. And we would be meeting again in around 3 months' time with another interesting session, and hope to catch up all of you at ISPAE Nagpur soon in November then.
Thank you so much.
Thank you.
Good night.
Good night.
Bye-bye and greetings to all of you. Stay well. Bye-bye.
Good night.
Bye.
Bye.
Can I end now, sir? Hello, sir. Can I end now?
I think so. I think so. We are done.
Okay, sir.
Dr. Zalak, if she is around.